study on the UCL and the Tommy John surgery. My name is Mitchell Fullerton, and I'll tell you a little bit about the background and the anatomy of the UCL. The history, Tommy John was a southpaw. He was a candidate, and he pitched for the LA Dodgers. He tore his UCL in July of 1974, which then was considered to be a career-ending injury. He then approached Dr. Frank Jobe, who was an orthopedic surgeon, and he kind of deplored Jobe to make something up to invent surgery that would make sense. Jobe invented a surgery, and he transplanted a ligament from Tommy's right forearm into his left elbow. There's a myth and kind of this rumor going around about the surgery that it increases the performance of the pitcher. This myth is so strong that there are Little League parents that request this surgery done on their uninjured children in order to increase their performance. Our group decided to seek the veracity of this claim, to figure out the truth. A little bit about the anatomy of the UCL. The UCL comes in 3 bundles. You have your interior, which is the first, number 1 on this diagram, your posterior, which is number 2, and your transverse, which is number 3. There are different fibers that make up these bundles. And these fibers are taut depending on your flexion or extension of the elbow. The first type of fiber, of course, being fully taut when you're fully extended. Second type of fiber being fully taut when you're in foot flexion. And then there's the intermediate fiber, which is taut somewhere medium in between these two. The fibers serve to guide the joint during movement, and that's why they're so important to your pitching.
I'm Michael Lewis. I'm just going to talk about the BioMechanics UCL injuries during pitching. So when a pitch is performed, it uses the entire body, beginning with your lower extremities and then moving and finishing with accurate movement of the trunk, shoulder, elbow, wrist, and hand. And the easiest way to analyze this mechanism is to break it up into 4 different phases. The windup, which sets the rhythm. If you look down at the pitch, you can kind of follow along. The next phase is cocking, which is where the velocity for the pitch is generated, and then acceleration, which uses an elastic force release to transfer energy from your shoulders through your pitching arm. The follow-through is a really important part because it's where deceleration takes place. And acceleration and follow-through is the most common phase where the injury is. And the cause is because of the high velocity activity and then trying to finish it and decelerate in a smooth manner. Go to the next one. Alright, so basically the UCL pulls the forearm forward during transition from cocking to acceleration, which is a fairly unnatural motion, given that the UCL is relatively small, and the motion is a jerking and really fast motion. Pretty much how a pitch is generated is through elastic energy, and this is a potential mechanical injury. The easiest way to think about this is shooting a rubber band. So you pull it back, and it creates this potential energy, and then when you let it go, it contracts and then turns into kinetic energy and then shoots. And when you think about it in muscles, it's called a stress shortening cycle. It's an eccentric contraction when the muscle doesn't change in length, followed by an immediate concentric contraction. The muscle is shortened, and this is how velocity is generated. Also, like all ligaments, the UCL helps stabilize and limits the range of motion during the deceleration. And like I said, it acts as a brake for the arm after large acceleration. You can see how this could be damaging, especially in high velocity pitches. Because if you think about the torsional stress equation, high amount of torque acting over the small area ligament can create stress that exceeds the yield strength of the UCL. And this creates micro tears. Actually, a common misconception that pitchers have is that one bad pitch is actually what causes the tear. And this isn't true. It's actually a combination of micro tears that propagate across UCL until it entirely tears.
Alright, I'm Natalie, and I'm going to talk about surgery and rehabilitation. So damage to the UCL usually leads to pain and instability in the elbow, and this is caused by a sprain of the UCL, which is a lengthening of the ligament, or a complete blowout when you can feel a pop in your elbow. A doctor usually prescribes rest, anti-inflammatory medicine, and physical therapy. And physical therapy consists of 2 3-month phases. If after these these 2 to 3 month phases, a person cannot do the throwing motion at 75% without pain, then surgery is recommended. And in a study done by Toulos and Barnes, half of the patients needed surgery after physical therapy. So when you have to have surgery, you're going to need a tendon to implant into the bone. And you want to use a natural tendon versus a synthetic tendon because natural tendons have better mechanical properties and synthetic tendons tend to fail over time due to repeated elongation, which leads to permanent deformation. And it fails because of stress shielding and fatigue. So there's a couple of tendon options. The first option is the palmaris longus, and it has like no function like where it is in the body, which is why it can be taken out and used in your elbow. And it can be found by touching your pinky and your thumb and making as much of a fist as possible. So it's right here. And 15% of the population doesn't have it. So that's why there's other options, which include the hamstring tendon, part of the Achilles tendon, and the plantaris tendon. Okay, so when surgery is needed, you're going to need to take out the tendon first from wherever the doctor decides to use it. And then they're going to need to expose the elbow and drill 3 holes. And 2 of the holes are in the humerus and 1 is in the ulna. And the tendons are planted and allowed to ligamentize. So you can see the 2 holes right here in the humerus and the 1 hole in the ulna. And then the tendon is implanted to ligamentize. So after surgery, the first 2 weeks, you have to be completely immobilized and you can't move the elbow at all. But then after the 2 weeks, you can start moving a little bit and start beginning your physical therapy. Once 9 months is reached, that's when you can do the throwing motion. And the total recovery time for each person is different, but it's usually around 15 months.
I'm going to talk about the post-surgery and the success rates for pitchers who receive UCL rehabilitation surgery. There's been a lot of research into post-operative rehabilitation. This is to minimize recuperation time and to maximize the chances of returning biomechanical stability to anatomically appropriate levels of functionality. Immediately after the surgery, a splint is used to immobilize the arm at 90 degrees of flexion. This is for initial wound healing. During this time, hand and wrist range of motion exercises performed to prevent stiffness. And a week after that, a range of motion brace is applied that permits flexion up to 100 degrees and extension up to 30 degrees. Every week after that, 10 degrees of flexion and 5 degrees of extension are added for up to 9 weeks. And after that 9-week period, initial activity exercises are permitted, such as light tossing. During this time, stretching and isotonic exercises are highly encouraged to permit muscle regrowth and to prevent stiffness in arm and elbow muscles. Near the end of the 9-week phase, where they're doing range of motion exercises with the elbow, they'll permit slight exercises and they'll begin testing out pitching motions again. At this time, sport-specific rehabilitation exercises are permitted, and in the 14 to 26 weeks afterwards, activity exercises like actually throwing pitches at full speed are encouraged to get pitchers back to full speed. In most cases, athletes are able to return to previous or exceed prior levels of competition within a year. As for performance, a study by the American Sports Medicine Institute in Birmingham, Alabama found that out of 67 UCL surgeries, 53, roughly 80% of the people or pitchers that received the surgery were able to exceed or return to previous levels of competition. This statistic was based off of comparing pre and post-surgery pitches per game and starts for pitchers. So post-operative success determined that this procedure is practically significant for pitchers who want to return to the mound. But as far as biomedical or biomechanical significance, a study by the Department of Orthopedic Surgery at Washington University's School of Medicine found that native UCL tissue is more biomechanically stable, showing that people who had UCL reconstruction surgery had a 53% decrease in maximal moments of failure of the ligament and a 75% decrease in ligament stiffness, and also a 56% increase in strain at the maximal force of the ligament, which shows that the replaced ligament is actually a little bit less biomechanically stable. The conclusions that we draw from this are that although athletes are able to return to and exceed previous levels of competition, this might be a misconception as these players are emphasizing stretching, pre-game stretching, and range of motion exercises, which is very important for any pitcher. And as far as UCL injury frequency goes, pitchers and other athletes with swinging motions in their arms are very prone to this kind of ailment. So surgery is an important option to understand